everyone, and welcome to this Trial Site News podcast. I'm Erin, your host, and today we are going to talk about MPox with a special guest, Dr. Dimie Ogoina. He's joining us from Nigeria, and he is an infectious disease doctor. He's the president of the Nigerian Infectious Disease Society. In 2023, he was named to the Time 100 of the most influential people in the world for his scientific contributions and global health equity efforts. And he also was one of the first people to raise the alarm on MPox spreading back in 2017 in Nigeria and the possibility of it spreading sexually. So, Dr. Ogoina, thank you so much for joining in.
Thank you very much for having me.
So we spoke in 2022 on my podcast, Causes or Cures, but a lot has changed since then. I'm in the US, as you know, and the general public, we don't necessarily follow infectious disease outbreaks in other countries until they land on our doorstep. For example, a lot of people never heard or talked about MPox until 2022, when the World Health Organization declared a public health emergency of international concern on July 23rd. Because while historically it was confined mostly to Central and West Africa, the 2022 outbreak saw cases spreading in Europe, the Americas, and other regions. And then in August of 2024, the World Health Organization declared another public health emergency of international concern after a surge of MPox cases in the Democratic Republic of the Congo and neighboring nations. We're going to get into the difference between 2022 and 2024. But first, you were way ahead of the game. So can you take us back to 2017 to what you saw happening with MPox in Nigeria and what made you sound the alarm bells?
Yeah, thank you very much. In 2017, we had an unusual outbreak of MPox in Nigeria. The index patient was reported in my hospital. We made a diagnosis of that case, and that was the first case we're reporting in Nigeria since 1978. So we had a silent period of about 38 years without a single case of MPox. Then in 2017, we had the first index case in my hospital. That case was a young boy, 11-year-old boy, who had, at that time, what people believed was a typical chicken pox. But there was a clinical suspicion of MPox, and ultimately, when the laboratory diagnosis came out, it turned out to be MPox. So it was a remarkable diagnosis that created a lot of, should I say, anxiety, fear, uncertainty amongst everybody, including clinicians, the general public, and even people in the government circles. Subsequently, what we observed in Nigeria was the subsequent cases were not children. The subsequent cases that were diagnosed were actually young adults between the ages of 20 to 40 years. Most of them were males, and a substantial number of them had what we describe as unusual clustering of these skin eruptions or skin rashes around the genital area. Also very unusual in that 2017 was that MPox before then was known to traditionally occur in rural areas, rainforest areas. But in the 2017 outbreak, we are seeing cases of MPox amongst adults in urban settlements. So it was very unusual to us at that time, especially in my center where I worked in Bayelsa State. So when I saw young adults having genital ulcers and clustering of lesions around the genital area, I was very curious about it. So we also decided to do a sexual history assessment. And we then observed that a number of them had high-risk sexual behavior, i.e. multiple sexual partners, transactional sex, and sex without use of condom. And so that made us at that time to make a proposal that there was a chance that MPox would be transmitted via sexual contact. That was in 2017. Unfortunately, that view was not widely accepted and was more or less ignored until the 2017 outbreak. Of course, as you are aware, in between 2019 and 2022, there was exportation of MPox from Nigeria to the US, to Israel, to Singapore, and the United States of America and the United Kingdom. That's just before the 2022 outbreak. But the 2022 outbreak just served to confirm what we observed in 2017.
So just to confirm for our listeners, you brought it to people's attention that, hey, this may be spreading sexually in 2017, and the response was not very helpful. Is that fair to
Yeah, so
say?
people were a bit skeptical about that finding because it was against the traditional knowledge of MPox. For before that observation was made in a hospital, before we made that observation, the traditional knowledge of MPox, and that traditional knowledge was up to about, I should say, over 40 years knowledge of MPox was that it was a primarily zoonotic disease transmitted from animal-human spillover events and contact-related non-sexual human transmission, especially amongst household. Nobody ever envisaged that mpox could be transmitted via sexual contact. So when that proposal was made, and that is regular behavior of scientists all over the world, historically, usually when you make a new finding, people always doubt. So people were not willing to accept that you are changing the traditional knowledge of mpox, that it was not a sexually transmitted disease. So that was one challenge. The second challenge is that at that time we were the only ones reporting that there is a potential that mpox will be transmitted via sexual contact. Nobody else was reporting it. So people felt that they did not have sufficient information to support our findings because we are the only ones reporting at that time. To that extent, a number of people that were aware of that finding were not actually willing to accept it because of that uncertainty, and also because they felt that it has not been replicated by anybody elsewhere.
Did things change for Nigeria after the declaration of the public health emergency of international concern in 2022?
Yeah, so 2022, a lot of things changed for Nigeria, and I believe also for many parts of Africa. The question will be whether it significantly or substantially changed. A lot of things changed. I said why? Because there was more awareness about mpox in Nigeria. There was also a little more investment regarding mpox, and also uh, more political commitment from government circles because of that awareness of the public health emergency created. And of course, part of the investment is collaboration, research collaboration. On account of the 2022 outbreak, a number of research collaborations came to the country. I'm aware of this because I'm personally involved in a number of these research collaborations in order to improve the understanding of mpox. But what is important, it is 2022, we're in 2024. Some of these collaborations is still in the preliminary phases. Some have started. Some are proposals that are being considered. What will be important is for us to do an assessment perhaps 5 years or 10 years later to see the impact of some of these collaborations before we can definitely say that these collaborations were very, 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 very useful. But it's also significant that during the 2022 outbreak, Nigeria, like most other African countries, did not get supplies of medical countermeasures, that is, in this case, vaccines. Nigeria only got its first supply this year. And that tells you that there was some inequity in the availability and distribution of vaccines, and Nigeria was also equally impacted.
Yes, and I wanted to bring that up and ask you about vaccines and when you first got the vaccines. Over here in the States, there was, a vaccine campaign against MPox, and some of them were prioritizing men who had sex with men uh, as the most vulnerable population. But you didn't get vaccines for MPox until 2024.
Yes, the vaccines were not available. There were commitments that were made.
Yeah.
Was that in 2023 that vaccines will get some vaccines, but uh, those commitments were only fulfilled in September 2024 when we had 10,000 doses of. Is it August, September? I can't remember the exact date now. When Nigeria had 10,000 doses of MVABN vaccines supplied, and that was the first time we were getting vaccines in the African continent.
All right, so now 2024, we have another public health emergency declaration due to what's happening in the DRC. Now the outbreak in Nigeria was caused by the West African clade, and the outbreak in the DRC involves a new strain within the Congo Basin clade, clade 1B. For our listeners, I suppose an easy way to think about that is they are different families of the virus related to each other, but evolved with different capabilities and such. So, what is different about this 2024 outbreak and this declaration of a public health emergency?
Yeah, so the 2024 outbreak is somewhat focused around the African continent because the African continent is bearing the worst burden in terms of morbidity and mortality associated with this outbreak of MPox. So since, in fact, many have argued that since 2023 December, cases of MPox have been rising progressively in the African continent, especially in the Democratic Republic of Congo, which is the epicenter for this current upsurge of MPox. So we have been seeing rising number of cases, and what is also remarkable is just the emergence of this new clade or new strain of the clade 1, because we know that the 2022 outbreak was due to clade 2, which was the West African clade, previously called the West African clade. Clade 1 is what was restricted to Central Africa, and it did not cause, was not associated with the global outbreak, but clade 1 was noticed to be causing an outbreak, an extensive outbreak in the DRC, extending beyond the rural areas even to urban settlements and affecting many more people than it used to. In fact, the estimate had it that there was an increase of about 160% cases reported if you compare the same period from 2023 and 2024, which is very, very remarkable. But what was also observed, because clade 1 has never been associated with sexual contact or sexual transmission or high-risk sexual behavior. But for the first time in 2024, they started noticing, it started in 2023, but became very intensified in 2024. They started noticing that clade 1 is also associated with sexual transmission. And then the emergence of a new clade 1, which is clade 1B, which is known to be predominantly sexually transmitted. Also of concern was the exportation, cross-border exportation of MPox from the DRC to neighboring Eastern African countries that had never reported a case of MPox. So, for instance, Rwanda, in these 54 years of MPox discovery and clinical presentation, Rwanda had never reported a case. Uganda had never reported a case. And some other countries in the Eastern African bloc that had never reported a case of MPox, such as Burundi, too, were reporting cases for the first time in history. And currently, we know that 15 African countries are currently having ongoing outbreaks of MPox, and amongst them, about 6 to 7 of them are reporting cases for the very first time in history, and a few others are also reporting cases for the first time in the last 2 years, because the last time some countries reported cases was in 2022. So this is a very remarkable and significant spread of MPox in terms of numbers, the morbidity and mortality, because in the DRC, for instance, the morbidity and mortality is said to be much higher amongst young children. And there's also cases of fatalities among pregnant women. And it's also compounded in the DRC by the humanitarian crisis, because the number of cases are also increasing. At the last count, we had close to 32,000 suspected cases that have been reported in the African continent since January to end of September. Unfortunately, it's just about 30 to 40% of these cases are tested, laboratory tested. So what that means is that we are largely, as I always say, largely working blindly, because we cannot fully estimate the true burden of MPox in Africa. But majority of the cases are with the DRC and Burundi. And the case of Burundi is a bit very significant, because Burundi had never reported a case. But following the report of the first case, subsequent weeks, they reported cases in about half of their districts across the country. And that to tell you that MPox was actually circulating in the country, but was not detected. And this is the same story that we know of Africa, that a number of cases in MPox are prevalent in Africa, but are not being detected because of weak surveillance system, lack of index of suspicion, and poor laboratory diagnosis.
So to summarize, it's safe to say that what our media has been reporting here in the States, that it's spreading faster, it's more aggressive, and it's more severe. Is that accurate to say that?
So again, we watch historically what you know about clade 1 is that clade 1 presents with more severe disease, and it's more associated with greater case fatality rates. The clade 1B now, we do not have complete data to be very certain about its case fatality and transmission dynamics. Because again, the setting in which it's being transmitted is a setting that a number of factors are confounding the actual determination of what is maybe responsible for the rates of transmission. Because currently the DRC is facing a concomitant humanitarian crisis, and they're also having other outbreaks of measles, cholera, and chickenpox. And also because people are displaced, they're in refugee camps, they don't have access to water, hygiene, and sanitation. And these are all the factors that will promote transmission of any infectious pathogen. And to that extent, the rates of transmission in the DRC may not necessarily be solely related to the virus itself. It may also be related to other factors that relates to social determinants of health and other factors that may promote transmission. But it's actually worrisome that the number of cases that have been reported in the DRC and being exported out of the DRC, especially Burundi and DRC, and most of these cases are related to clade 1B. And in the DRC, for instance, in the urban settlements and northern part of DRC, the number of cases that have been reported are somewhat exponential and related to sexual networks. And of course, we have known that in parts of Kenya, for instance, which is also one of the countries reporting cases, and even in Rwanda, cases of clade 1B have been associated with long-distance truck drivers, which traditionally is known as one of the ways that fueled the HIV pandemic in Africa. So it seems as if the sexually transmitted MPox is somewhat replicating the history of the known history of HIV/AIDS pandemic. So just to summarize, what we know now is that there is some level of faster transmission of the clade 1, but we're not sure whether it's due to the biological property of the virus itself or due to other factors that might be contributing to this faster transmission and more cases being reported.
Thank you for that. And to go back to the case fatality rate, and for folks who are listening, that's the number of people who are diagnosed with MPox and who die. Can you comment on how we interpret the case fatality rate maybe in a wealthy nation like the US versus a country that has limited resources? It's safe to say we can't equate the two necessarily.
Yeah, so it becomes very difficult to equate the two, and sometimes we can underinflate or overinflate the case fatality rate because case fatality rate also is determined by your case detection rate, both suspected, confirmed cases, and also perhaps cases that die. And if you are not able to confirm cases that have died, maybe they are due to MPox, it means that you may underestimate your case fatality rate. In the same vein, if you have so many confirmed cases, you might also underestimate, and perhaps you are not having the complete picture. The other thing that is also important is that the level of care that is being that is associated with an illness. The level of care in developed countries is much higher than that in developing countries. For instance, in 2003, there was an outbreak of MPox in the United States of America, where about 47 confirmed and probable cases were reported. And a number of cases even had severe infections. I think 3 patients required ICU admission, but no patient died because they all received prompt and high priority care at that time. So lives were saved. But if the same thing happened in the African continent, we have challenges with health system, lack of human resources, social amenities, poverty, and the like. So these are contributing factors that result to death and even late presentation. I've had cases in my country, in Nigeria, where people have died not because the disease was supposed to cause death per se, but because they presented late when they had complications. So there are several variables that may determine case fatality. And people have argued that the case fatality in the African continent is still an underestimate because a number of case fatality are actually calculated based on confirmed cases. And a number of the cases we are reporting in Africa now, including people that have died, are not confirmed cases. And to that extent, it is probable that case fatality can be underestimated. It's also probable that the case fatality can be underestimated because ultimately, if all the cases that are suspected are confirmed, it will dilute the number of, if you understand what I mean, the number of the calculation of the case fatality rate. So whereas the global outbreak, the case fatality is less than 1%, the clade 1, or what they call the clade 1A, the case fatality is between 3 to 5%. The clade 1B, the last estimate, the case fatality was about 1.4%, so that's less than 2%, which is much higher than the clade 2B in the global outbreak. But also to say that the experience we have for clade 2B in the West African continent, case fatality has also ranged from 1% to 6%. For instance, in the 2017 outbreak in Nigeria, we had the highest case fatality rate of about 6%. And a substantial number of our patients that were passed on were people living with HIV. And HIV infection is a significant variable that may sort of impact on and change the dynamics of MPox in Africa if we do not tackle this problem. Because we have a significant burden of HIV, especially people newly diagnosed and not receiving antiretroviral drugs or not virologically suppressed. And these are the group of persons that have more severe disease and are more likely to die, apart from children and pregnant women.
Now, you are advising the World Health Organization on the response. Is that correct?
Yeah, so I'm a member of the WHO Emergency Committee, and I'm also the chair of the committee. Yes.
Okay, so when they declared this public health emergency in August of 2024, has anything changed? Has anything been mobilized, in your opinion, regarding resources or helping to control this outbreak?
So I think a lot of things have changed. As you are aware, that the African CDC was the first to declare this outbreak an emergency a day after the WHO then declared the outbreak as an emergency. And what the essence of declaring such an outbreak as an emergency is one, to see how you could increase awareness about the problem. And I always tell people that a public health emergency of international concern is more preventive than even curative, because ultimately what you want to do is to avert more cases, avert transmission, try and manage cases, and then prevent the problem from becoming a significant problem. That's what is very important. And so since this outbreak was declared as a public health emergency, a number of steps have been taken by the WHO and the African CDC. And the African CDC, for the first time, is also working in close conjunction with the WHO to see that this problem is addressed. And I would say that the African CDC is taking more or less a leadership position because this problem is peculiar to the African continent. And there have been several, I think the last time I checked, there are commitments close to about $1 billion contributions, commitments. And out of that amount, maybe 40% or so is now available to the African CDC. There's also support for vaccines. There are commitments for close to 6 million doses of MPox vaccines to be available in the African continent. And I think out of that amount or so, 300,000 is currently available in the African continent for distribution to other countries. WHO has undertaken emergency use authorization, for instance, for the MVA-BN vaccines, and that gives the authority to organizations such as UNICEF, Gavi, and other organizations to procure these vaccines for distributions. And I'm aware that UNICEF and other organizations are also making plans for procurement and also negotiating deals with manufacturers to see how these vaccines can be procured and extended to African continents. And I know that WHO also made a request that companies and manufacturers to submit their whatever they have regarding rapid diagnostics and diagnosis related to MPox. And recently, I think we heard of emergency use authorization for a more rapid PCR, real-time PCR-based monkeypox, MPox diagnostic that can improve case detection in the African continent. But of course, it's too early for us to know what the exact benefit of this will be. There has been policy changes, and the African continent, in terms of the political leaders, are showing more commitment. Even countries that are most impacted, for instance, the DRC, the government of the DRC has release direct funds from governments themselves to see that this outbreak is addressed. And I know we have had several meetings at the level of the WHO and the African CDC to look at the research and development agenda for MPox. And the idea is that MPox has been neglected for so long. There are so many unknowns about MPox. For instance, we are not sure of the animal reservoir. We are not too clear about the natural history of MPox. It took us the 2022 outbreak to start doing clinical efficacy trials on MPox. So many unknowns. And I remember we have had a meeting where we have outlined what the priority research agenda for MPox is. And the African continent has been mobilized. Researchers and government have been mobilized to ensure that this is done. So I think a lot has happened. What I've always said is that what is most important is sustainability, because ultimately in 2022, there was some fire about MPox, some optimism about MPox, but it was not sustained. And that's why African continents did not have access to vaccines and other medical countermeasures. Some help is coming to Africa now. There are some commitments, but can we sustain it beyond 6 months, beyond 1 year? Because the problem that we have lost for 54 years, we can't solve that problem in 6 months. That's the truth, even in 1 year. And the responsibility doesn't lie with the global north alone. It lies with the African continent, our leaders, our researchers, our scientists. We need to do the work while we're seeking for global support.
So it sounds like there's been some progress, but the main issue is sustainability, in your opinion. Can you sustain this? Which makes a lot of sense, of course.
Yeah, yes.
Speaking of sustainability, since you're an infectious disease guru here, there's been a lot of chatter in the global health community about how to prioritize manufacturing capabilities of vaccines in Africa. Do you see anything happening on that front? Do you see that as a possibility of a way forward to help with the sustainability issue?
So I think we need to play a lot of advocacy. We need to look inwards. We need to, as much as possible. I've always said the problem we have in Africa is lack of development. If we can develop, we will solve our problems. What I've noticed over time, I've said to many people that there are 3 things that influence global health decision and even availability of medical countermeasures, of manufacturing capacity as it relates to global health. One is interest, especially national interest. The second is noise. And this noise, especially global noise that comes from the global north, a significant noise. Then the other one is what I call profit. These are the 3 factors that I've observed over time that influences, especially the availability of medical countermeasures. Unfortunately, we don't have the wherewithal in Africa due to historical neglect, issues of colonialism, and so many other factors, corruption, lack of accountability, and other historical factors that have made us a little backward compared to the global north. And when you see vaccines or therapeutics being developed, or where the manufacturing companies in the global north are interested in vaccines or therapeutics, it's either there's profit involved, the interest of the global north is involved, or there's a lot of noise, especially in the global north media. Everything that is developed related to vaccines and therapeutics revolves around this. For 54 years, we had MPox. We did not talk about vaccines. We did not talk about clinical efficacy trials. It is only in 2022 where the interest of the global north became at stake. And of course, when the interest of the global north became at stake, they needed the vaccines, and the manufacturing companies could make profits. And there was a lot of noise about MPox at that time. And as such, manufacturing companies started making vaccines, and they continue to make vaccines. Where in 2024, this public health emergency has been declared by the WHO and African CDC. It's a lot of noise too. And now cases are also coming up outside Africa of Clade 1B. And so there is a feeling that there is some national interest outside Africa. There is some noise involved. And since WHO is involved, UNICEF is involved, Gavi is involved, many other organizations are involved. Most of these pharmaceutical companies have the potential to also make profit. But the question is for how long? That is why we need to invest in Africa, because ultimately we can't survive on handouts. We can't run our public health system on handouts, because ultimately we're always waiting for support from the global north. And if we are doing it in such a way, when the noise is no longer there, when the profit cannot be determined, and when there is no national interest, there will be no medical countermeasures for Africa. And that's the truth. And that is what we need to focus on.
Thank you, Dr. Ogoina. You gave us a lot to think about, and thank you for providing some details and really answering a lot of our questions we had about MPox. And I certainly will think about a lot of these things from a public health perspective as well. And it's always a pleasure to chat with you. And to our listeners, thank you for tuning in. I hope you subscribe and share this video, and check out trialsitenews.com for research on clinical trials, epidemics, and other public health interest around the world. So